Thanks to the Center for Rural Health for inviting me to do it. If you don't know me, I've been at the state since February, but I have been a paramedic for a little while. I worked at Jackson Community Ambulance. I still do very part-time, but I've worked there since the December of 2000, so a little while. And I'm really glad to be a part of the state EMS office and to bring this information to you. So to start off, we have the obligatory objectives slide as to what we're going to do and talk about this evening. The objectives are, we're going to talk about the importance of pharmacology for the EMS provider of all levels, not just paramedics. We're going to talk about the new trends in medication use and what might be on the horizon for protocols and patient treatment. I use the word might because there are some that are still out for public comment until the 20th of this month, so I can't say anything is absolutely official because I might get vetoed. And then lastly, we're going to talk about the issues that these medication shortages we've been having and how we can, as providers, can work within the system to kind of deal with those and help alleviate them. So that's kind of what we're going to chat about. So what I want to kind of start off with here is, I would say, a fundamental shift in what we do as providers. Well, a lot of people, when the EMS was kind of come to fruition, it was pretty much we just like picked people up and took them to where they wanted to be. And that's kind of our fundamental issue that we deal with all the time, is that we're looked at as a transportation system instead of a treatment system. And I don't mean like within ourselves, I mean from outside looking in. So those days are long gone, as you guys all know, that we are real providers, we're practitioners of medicine, and we do a really great job of taking care of patients. And part of that is making sure that we understand things kind of even beyond what people expect us to. So we need to be patient-centered people who take care of the situation that's at hand and provide a level of customer service that makes us invaluable to the communities that we serve. So it's beyond, oh, maybe we'll see you once when I have a car accident, and it's become more of a community-based service where we're involved in more things. So as far as medications go, I feel like there isn't a day that I go to work that someone isn't talking about a different medication, or who can give a medication, or can we add this medication? And we are adding them and using them all of the time. It is not something anymore that we're thinking, oh, one every 100 or so calls, I change a drug box or a drug bag. We're doing it pretty often, and we're expected to do it pretty often. And I feel like as someone who has been a utilizer of healthcare, that's probably fair. If you have the training to use a tool and you have that tool with you, it should be expected that you would use it to fix the situation that I have. So all of us, even our MFRs, are being asked, not everywhere yet, but we are being asked to learn things and adapt to things. If you're in an area that, for example, is doing the maybe study, where you are drawing and administering medications that previously had been paramedic level skills, that's pretty impressive. Every one of you is smart enough to be able to do this stuff. So the expansion of scope, it keeps going. And a lot of this has come in the state of Michigan from the more rural communities, because you guys are out there on the forefront and waiting for a long time. So if there are things that we can teach you to do and things that you can take with you to help your patient outcomes, then we should be doing that. So the parallel to that is, if we keep adding more tools, we probably need to add more instructions as well. So we have to make sure that we keep our education up in order to meet the demand that we're putting on the providers to make sure they keep increasing what they're doing. So this is kind of a tertiary thing. When we start talking about patients, the actual people that we deal with, polypharmacy is a real thing. We actually heard someone, I was just at a conference and someone was talking about this particular thing, we are the people who patients say, hey, come on into my house and you can see the environment in which I live. And that's pretty special privilege that we have. So we see the bag of medication or the box of medication or the fact that they have 6 different bottles of the same medication, and no one else sees that. So it's kind of a burden on us to make sure that we're looking at that stuff when we're there. It's not just about copying it down on a list of medicines. It's about paying attention to what we're reading, because there's really no sign of that stopping as patients go to different physicians and different pharmacies. I mean, I'm sure all of you have gotten one of those things that say, hey, I'll give you $10 off your next purchase if you move a prescription over here. People are doing that. If you think about people who are on fixed incomes, $10 to a grocery store is $10. So they're moving one of their prescriptions to Meijer and one of their prescriptions to CVS and one of their prescriptions to Rite Aid. And then all of a sudden they have 6 different pharmacies filling their medications, and none of them know that they're doing it other than us, because we're the ones who see all of the labels. So it's important that we pay attention to that stuff. As far as knowing what prescription medications do, and I know people get kind of frustrated with this, it's pretty important, because we know that patients don't know what their prescriptions do and what they're for. So when we go and we're looking at a patient and we look at this, that they've taken this extra medicine because they had it filled 3 times, we should have some sort of an idea about what that's going to do to them. And I know you're sitting there and you're thinking, Emily, you're crazy. There are a million medicines out there. And I know that, I do. But you have to be a little bit proactive. And if that means that you take your phone out and you Google that medicine, that's okay. That's totally okay. Because who knows if the syncopal episode that the patient had, or the swelling that they're having, or their nausea, or whatever, whether it's related to the medicines or not. Because chances are they don't actually know that. So if we start looking into, and I don't mean Google every single medicine that they have, because if they're on 50, you could be there for 2 days. But if they have a new medicine or a medicine that they're taking extra or not enough, that's when we need to start looking at it. And I'll do a true life confession for you. I look up every medicine I don't know. So when I work on the ambulance and I have a patient and they have a medicine that I don't know what it is, I look it up after the fact. So I do like a tertiary quick, this is what it's for. Then after the fact, I go and I look it up. People always say, well, how do you know so much stuff about medicines? It's because anytime I see one that I don't know or I don't understand, I look it up. And I may not remember it exactly, and I may not know all of the really specific things about it, but if every time I don't know it, I look it up again, chances are there is going to be a little bit of it that's going to stick with me, because Lord knows I have a hard head. So that's my, soapbox on medicines and why we all need to know it. So I guess moving along to what we're going to talk about for quite a while here is the state minimum protocols. As you guys may or may not know, the new set is being released on October 25th. So probably towards the middle of the day, I would guess, because I have to make someone else put it up on the website for me after we present them. But they do have a lot of fundamental changes. And some of them people are going to love, and some of them people are going to be pretty skeptical of. But I want to make sure that I convey here that the things that are changed are for real reasons. I can't even explain how many articles I have read and people I have talked to and phone calls I have fielded about these. We are really trying to give everyone the best tools that we possibly can, and really kind of stretched ourselves to think outside the box. So you'll see a lot of change in these. So the first one I'm going to talk about is the seizure protocol. And this one was probably the one that I thought, holy smokes, I can't believe I've been doing this wrong for so long. And this one is based on a real study that's called the Rampart study, and it was done several years ago, actually, in Detroit. And if you think about seizure calls and the fundamental basis behind them is probably 99% of the time when we get dispatched to a seizure, when we get there, the patient's not still seizing, right? They had a seizure, whether it's at Kroger or whatever, they had a seizure, and by the time we got there, they're not seizing anymore. Very rarely do we see them actually having a seizure. And where we need to fundamentally switch our brain on to is that if we see someone seizing, it's one, probably not their first seizure, or two, it's status epilepticus, because think about it, seizures usually take less than 2 minutes. And how often as EMS providers, from the time of 911 call to the time I put eyes on that patient, is it less than 2 minutes? It's probably not. So when we're looking at a patient and they're seizing, holy smokes, they've been seizing for a while, or they're not going to come out of it themselves. So this is something that we really have to think about. So then it comes to the point where maybe I shouldn't try to hold down a seizing patient, start an IV, and give the medicine that I have always given in order to stop the seizure. They've already been seizing for a little bit, and they haven't been getting appropriate oxygen during that time. So we need to do the fastest and most effective thing. And the fastest and most effective thing is to do an intramuscular injection of Versed or midazolam. I'm going to try to use midazolam for you guys, but we all know that Versed is easier to say. So if I slip up and say that, that is the name brand. Midazolam is the generic term for it. It's always been an option for an MCA, for your medical control to carry it. Not everyone has always opted into it. People have chosen Valium instead or a different medication depending, but none of them are as fast in that route at stopping a seizure than Versed or midazolam. So if we think about it, if it's our family member who's seizing and that's our person that's been doing it for several minutes waiting for an ambulance to get there, the last thing we want someone to do is stop and try to get an IV on a seizing patient, which is super hard, and then give a medication that we could have given faster and more effectively IM. So I know that for the paramedics who are listening, you're like, holy smokes. But that is fundamentally something that I kind of wanted to kick myself for, but this is what we should be doing, and that's why we're changing that. There will be still an option for after the intramuscular injection in a seizure patient, or if an IV has been established, they can, your medical director will be able to choose different medicines, but Versed will be something that they will have to have, or they will have to go through the quality assurance task force to change it. So also, this is some other tertiary stuff about why Versed is, or midazolam is better. It has some more stability. It's more stable in room temperature, which, you know, we have quote unquote room temperature in ambulances. We do the best we can. It's more stable than the diazepam or Valium is. And then there's several studies, and when Emma puts this PowerPoint up, you'll be able to click on these and kind of go and look at them if you are super interested, or you can ask me questions about it, because they are from the National Institute of Health, so they are not articles that are easy reads. That's what I will say. So that's our first big fundamental change. So the next thing I'm going to talk about here is the pain management protocol, and I'm sure if you are around anyone who has looked at these, this protocol, there's two. This is one of them that I have gotten more comments than anything else, and this is a culture change for us. When I started 17 years ago almost, we didn't really treat pain. It wasn't a thing that we did. Unless you had a bone sticking out of your leg or something that made me sick to my stomach, you probably weren't going to get anything for pain. And then there was kind of a fundamental shift where management started leaning on everyone, and everybody wanted our patient satisfaction scores to be better, and we needed to treat pain. And really, we were doing it for all of the wrong reasons. So I want to talk a little bit about this culture change that we're trying to go through here, where we're treating the patient appropriately. So instead of having nothing or opiates as our pain management options, we're trying to kind of broaden everybody's perspective into thinking about other things that make you feel better. So if you think about like your patient with back pain, for example, if you ever have had back pain, you know that there are positions that you can put yourself into that are more comfortable than others. I have had a few fractures in my lifetime, and I know that there were more comfortable positions that I could put myself into or that someone could help me with that made my pain better. So that is a skill that every single one of us, even if we're not at work, if we're just, we come upon an accident or something like that, that is something easy and simple that we can do to help somebody with pain. We can comfort them and empathize with them, and then we can do our rudimentary splinting so that they stop instinctually trying to move around. And I think that we lose sight of the fact that splinting is something that is a real thing, not just that it's going to make their pain go away, because it's not, but it is going to keep them from moving whatever that is around. So you think about, as I'm sitting here and talking to you, I'm moving my hands around. I kind of probably look ridiculous in my office, but if I'm a patient and I have a broken arm, I don't think about it all the time until it hurts me. So if I don't have a splint on it, I'm going to instinctually try to move it, and it's going to cause me greater pain. So easy things, simple things for us to do that are not necessarily jumping right to the spectrum of, knocking someone near unconscious with pain medication. Because all of the science says that if we treat someone's pain, no matter what it is, they actually heal better, which is kind of amazing. If someone is comforted and not in excruciating pain, they're not constantly in some sort of, I'm going to try to pick a good word for this, panicky state. When you have pain, you think about the adrenaline that's released. If you're having constant pain, you're constantly having adrenaline releases, and your pain is never alleviated, and you're never actually starting the healing process. So we have to keep that in mind. The sooner that we can help them, the sooner that they can get on that path. So then the second part of the protocol itself is non-opiate analgesia, meaning we're keeping morphine and fentanyl in the protocols, but we're making them kind of a secondary thing. So yes, if you have a bone sticking out of your leg, absolutely, you should be getting some sort of super strong medication. But we want you to have the tools that you need to treat a patient. So what if a patient is having a kidney stone, or what if a patient is having pain, but you're not really sure if it's appropriate to give them an opiate, a fentanyl, or a morphine? Let's look at some different options. And so these are the things that will be options. Ketamine will not be, but ibuprofen and Tylenol are options in the new protocols so that you can carry it. And I know that there are naysayers out there that are grumbling up their face, and they say if ibuprofen or Tylenol is appropriate, then they shouldn't be in our ambulance. But this is exactly what I'm talking about in our fundamental culture change, where if they're having a little bit of pain, but they also have some sort of other complicating thing, there's no reason we can't just do something about their little bit of pain. So then Toradol or ketorolac, that medication is something that we had before where I worked, and then it went away. But that medicine is actually really good for kidney stones, 1, and 2, it's kind of like IV Tylenol. So it works a little bit faster than an oral pill does, and it will actually take the edge off a lot of different types of pain without causing any sort of side effects that have to do with breathing or blood pressure, things like that. And then ketamine, we're going to talk a lot about in a minute. So I'm going to leave that one there, but that one is a non-opiate, but it is also an analgesic, an anesthetic, and a few other things. And we'll talk about that a little bit more. And And then, of course, we're not taking away the opiates when they're needed. If someone is having significant and severe pain, absolutely they should still be getting these opiate medications, but they should be secondary to ketamine, and that's why we have moved it to post-radio. And there's still some back and forth about how that's going to work, so that's one of those might things. But if we're already sedating someone with one medication and then we're going to add something else on top of it, we probably need to think about doing it in conjunction with a physician. So that is that about our opiates. So let's talk a little bit about ketamine and why it was chosen. And there are going to be many links for you to look at as far as why it was chosen and stuff. There's many articles that I linked in here for you to see after the fact. It's a versatile medication. We can use it as an anesthetic, meaning changer or stopper of pain, sedative, amnesiac, like for those of you who are know what Versed does, it also has that same effect to it, and analgesic. So not only is it helping with your pain, but it's helping you forget that you're having pain, which is a pretty pleasant combination for patients. So we can use it for behavioral control. It can be used in different levels, and we'll talk about the dosing of it here in a second. From low dose to high dose, everywhere from just taking the edge off a patient who's anxious to chemically restraining, or in essence, knocking down somebody who's having an excited delirium syndrome situation, where we can take a little bit and do a little bit of work for the patient, or we can give them more and actually truly sedate them. So analgesia, when we talk about this one is a low dose treatment for it. What is really cool about it is it does not have the side effect profile that an opiate does. It does not lower blood pressure or decrease your respiratory drive. It absorbs intranasally very, very quickly. So think about the concept of we could treat someone's pain before we start an IV on a patient. Someone who's in excruciating pain and then you stab them with a needle probably doesn't like you very much. So if you gave them a little bit of ketamine intranasally, then you could take the edge off of their pain and then move forward from there. And then it also, I would be remiss if I didn't mention the opioid epidemic while we're on this pharmacology webinar, but it allows for lower doses or no need for opiates at all. So there have been many articles that if you really want to treat someone's pain, it's the combination of the two, ketamine and opiates together. But there have been many, many patients that have been treated with it that didn't need the opioids anymore at all. And we have to do, I'm not saying that we were the starter of the problems, but just because we weren't the starter of the problems doesn't mean we shouldn't be a part of the solution. So that's kind of what I said. It preserves the airway responses. It actually is pressure supportive, meaning it can actually keep a patient's blood pressure up when they're having some sort of traumatic incident, and it's inexpensive. The hospital pharmacies get after us sometimes when we start thinking intergalactically about medications, and they say, well, did you even think about how much it costs? We do actually have a pharmacist that sits with us when I develop these protocols, and she keeps pretty good track of me. And this one is actually pretty inexpensive for the hospitals to have to provide. So then I'm going to stop here, and someone who works in our office, when this ketamine, the name came out the first time, someone said, that's a powerful horse tranquilizer, because it was something that they had seen in a movie, which I have not seen the movie, but apparently it's a very popular one. So this is where we've been kind of butting heads. Is ketamine really safe for patients? So I heard people hallucinate. That was one of the things that has been brought to my attention. It's true. People have hallucinated with ketamine. They call it dissociating, and they can, see things or hear things that aren't there. But one, it generally only happens with repeat boluses of the medication, which we are not encouraging anyone bolus their patients with ketamine, nor more than one time, especially. And then it's only occasional occurrence. And what's cool about it is the patient will still follow your directions. So if someone does say that they're seeing purple elephants, for example, you can say, no, you're not, you're in an ambulance, you had an accident, and they will actually still respond to you. So it's not as dangerous as what it sounds right off the bat when you hear the word hallucinate. So then it causes airway compromise. It is also true that drooling is possible, and you'll see if you go on the interwebs and look at YouTube, there are many videos of different treatments being done with ketamine conscious sedation. That is not what we're doing. We are not dosing at those levels, with the exception of excited delirium, but that's a whole other animal. When we have a conscious patient, we're not giving them medications to the point that they should be there. But if they are drooling, we can totally suction them. It is a tool that you already have in your toolbox. And secondly, they are also capable still of following your directions. So you can actually look at the patient and say, hey, you're drooling, why don't you go ahead and swallow? So then you don't have to worry about whether or not they're going to choke on it. So this one, it increases intracranial pressure, which I guess sort of follows if you talk about the fact that it's pressure supportive for blood pressures. It doesn't. And I will send you the article, but there was no way I could actually try to cover that in a pharmacology lecture that was meant for everyone in the whole state. It's actually covered in a couple of different articles that are linked in here, but it doesn't. They've tested it and CT'd and MRI'd and all that people, and it doesn't. They're not really sure why, because, you know, brains are tricky, but it doesn't increase intracranial pressure. It kind of supports blood pressure as it drops, but it doesn't like create more blood flow to the brain and squish your brain or anything like that. So when we talk about dosing the ketamine, it kind of depends on what you're doing. As I said before, when you see the ketamine at first as a colorless liquid, it comes in several concentrations, and we're going to talk about concentration a little bit today too, but be sure that when your providers are drawing up the medications that we're double checking to make sure, because it does come in several concentrations. And how much you're going to use for a patient is going to entirely depend on what you're trying to accomplish, right? So if I have a patient that I'm just trying to take the edge off, I'm only going to give them a little bit. It's kind of like if you're painting your room. If you want it to just have a little shade, you might only use a little bit of tint. But if you want it to be really dark, you're going to have to use a lot more. So pain management is our lowest dosing regimen that we have at 0.25 milligrams per kilogram. And that is for all ages, which I find positive because we're giving the dosing regimen is the same for kids as it is for adults. And that makes things a little bit more convenient and easy to remember. So the maximum single dose is 25 milligrams, meaning a 100-pound person is going to get 25, or a 100-kilogram person, that's 225 or 220 pounds, is going to get that dose. So there are going to be lower doses, but you're never going to go over that dose, even if the person weighs 300 pounds. That's all they're getting. Otherwise, you are going to end up with the disassociation. That's why it's important to keep it there. And then you can give it again if you need to later in 10 to 15 minutes. And you can give it intranasally, as I said before, which is pretty cool if they're having a lot of pain and you're trying to get your IV and stuff around, or they're in a car or whatever. If you can give it intranasally, you'll relieve their pain a lot faster. So then sedation, this is the 0.2. Remember, this is the I'm just going to take the edge off. So you have someone who is a little bit agitated, or they're super nervous, or the person is being paced, so they're having a constant irritating thing happening to them. This is a thing that would be good for them. You administer it slowly, it's a low dose, so you're not putting yourself at a lot of risk of like losing the patient's consciousness or anything like that. Then we start to get into these larger doses. So chemical restraint. So this is if a patient is, you know, fighting and belligerent, or you have them restrained already and they're still fighting, right? Because that's a dangerous situation, not just for you, but for them. It's not appropriate to leave them, you know, thrashing around and still tied down. You can do something about it. So it's a higher dose, but it is not intravenously. We are not restraining someone chemically who we were capable of starting an IV on. And I hope that makes sense to you guys. If they're compliant enough that I can start an IV, they're probably compliant enough that I don't need to darn near knock them unconscious. So these are intramuscular or intranasal doses, 4 milligrams per kilogram. So if you see that, that is a lot more, 16 times more than what we're giving for pain. So you should kind of rattle your head around thinking about that. And then that goes kind of hand in hand with the excited delirium dose. And so these are patients that are doing things or being in a way that is going to get them hurt or dead because they're not doing what they're supposed to be doing. So 4 milligrams per kilogram is for when someone is so non-compliant that they've become a danger to themselves or others. That's when we start using these higher doses to try to really slow a person down. And I put, some people say 5 because when we looked at this protocol, there were, I think for an hour, 6 physicians discussing whether it was going to be 4 milligrams per kilogram or 5 milligrams per kilogram. So we're going to put it out at 4, and then if your medical director is really that passionate about it, you might see it at 5 milligrams per kilogram. I would prefer to keep them the same, if for no other reason than at least you don't have to learn 100 different dosing regimens for this medicine. Okay, I'm going to leave ketamine for now, and I will answer any questions you have about it at the end. So medication shortages, if you happen to work somewhere where you have not had to deal with the medication shortage, you're super lucky, 1, and 2, that's probably going to change. And that's specifically because of the 1, 2, 3, 4th thing down, natural disasters. We've had a lot of hurricanes lately, and medication factories have been affected. So I can't imagine that it's going to be very long before we're going to start seeing a few more shortages. So why do they happen? Manufacturing difficulties is actually the one that's been giving us the hardest time lately. The shortages that we've had with dextrose and epinephrine and stuff have not actually been related to the medication themselves. It's been related to the glass vials in which they come. So they had some sort of sanitation issue or something or another, and so they didn't make these glass vials. So that was why we were having these, it was actually the syringes, I should say, that were the problem. So there's a lot of reasons why. I like to point out the supply and demand one too, and economics, because a while ago there was an epinephrine shortage because one of the factories that manufactured epinephrine just decided they weren't going to manufacture epinephrine anymore. They were like, this medicine is actually not that profitable for us, so there's other people that make it, so we're going to just stop doing it. And that's all well and good, but when you just turn a faucet off without any kind of notice, then you create some certain problems. So we're going to talk about like why this is an issue, and there isn't really a warning system. So there's no like, hey, coming out in a year, there's going to be some sort of a situation and we're going to slow down production. The medication manufacturers only have to tell the FDA that they're going to stop making the medicine 6 months in advance, only if they're stopping entirely and only if the medication is considered a medically necessary component of treatment. And that when I put that in quotation marks specifically because nobody really has a definition of what medically necessary is. So these people they're smart, right? They're smart business people. And they're saying, oh, well, we're not going to stop entirely, but we're going to close 2 of our factories that make it, and we're going to go down to 1. So we're giving, 1/3 of what we used to. So we don't have to tell you because we're not stopping entirely. Or they're going to say it's not medically necessary because somebody else makes it in a different concentration. So they run into some significant problems because it takes a lot longer than 6 months for someone else to come up and make that medication, 1, and 2, it has to be a financial incentive. So the government can't come out and be like, hey, you have to make that medicine right now. I said so. There's no method for that to happen. So if someone did decide, to stop making epinephrine because it's not very financially motivated, and I should say that's not EpiPens. I'm sure you're all thinking you're crazy, Emily, because they are expensive. This is the IV epinephrine. There has to be a reason for them to do it. So to start up and create the formula and make the factory do it takes a little while, and so that because it's going to cost them money, they have to have some sort of promise of making money. So then your hospitals and your pharmacies, when they go to order medications, that's when they find out there's going to be a shortage. The distributors don't shoot an email out to all the hospitals and say, hey, we only got in 10 of the 20 cases we ordered. Your hospital system says, hey, I need to order, 4 cases of dextrose, and the distributor says, sorry, it's on back order. And there's no real reason or given to them or timeline given to them, and then all of a sudden they're scrambling. So this last dextrose shortage that we had, I actually had someone call me in my office and say, hey, Emily, we only have 4 doses of dextrose left. So we had to come up with something to do really fast. And we just used a different concentration, but it's something to keep in mind that, things can happen relatively quickly and we all have to be a little adaptive. So I actually went to a webinar myself and learned about what the federal government expects us to do when it comes to these medication shortages and how we deal with them specifically. And they talk about 3 different avenues: conservation, substitution, and adaptation. Conservation meaning not using as much, substitution meaning using something completely different, and adaptation meaning changing the way that we use what we have. So we'll talk a little bit about that. So conservation is not usually something that we do, and that should kind of make sense because we don't usually say, hey, that medicine that we carry, it's not actually necessary. It's a tertiary medication that we carry around, so it's cool if we don't use it today. Our medications that we carry around are considered medically necessary to us. They're part of our protocols. Our physicians wouldn't have given them to us if they weren't. So it's not usually something that we do. So, but these are things that do happen where they stop utilizing it unless it's absolutely necessary. I guess the one I can use example here is sodium bicarbonate. That one used to be something that we used in cardiac arrest all of the time. It was like a Hail Mary pass that we tried. But now, because of the shortages and stuff, we really should only be using it when we have a person who has some sort of kidney problem that we think might have led to the arrest itself. So that's a conservation. Decreasing the dose, we don't do this, and then let patients use their own. So the example of that is, so say a patient's going to be admitted to the hospital and they just got their 90-day prescription filled with a medication, and that medication is on shortage. A hospital may let a patient bring their own medication from home to use if they can't get it for them. So not really our thing, but something that does happen. Substitution, that's a switch list for that. There is a new protocol coming out in the set that is a medication substitution protocol. And I know we've had one that was a little bit different before that was called medication shortage. But what this one does is it outlines for the pharmacy what are considered reasonable substitutes that you can go ahead and just use instead of having to write an emergency protocol. So when we ran into the dextrose problem earlier this year, everyone who hadn't previously had to kind of come up with an emergency protocol to get the different concentration of dextrose. The new set has some standard ones. And so it might be, if we don't have Versed and we can't get it, then I guess we're going to use Valium instead. Or if we can't get morphine, then we can use fentanyl, stuff like that, where the pharmacists have a guiding document for what they should do if they run out of a medication. They will still be marked of the change. I think it's a green label, depends on where you are, but there should be a medication substitution label placed on your drug box or bag so you know that something different is there. And if you do see those, please take a minute to review the new one because the medication might have a different dose. We try to keep them as similar as we could, but some medications don't have a direct formulary to them. So that is coming out as well. And then the last one using things in a different way. You might use a different route, like an oral medication versus an IV medication, or an IV versus an oral. You might use an alternate concentration, and I'm going to talk a little bit about concentration today. And then you might use an expired medication. Don't do that yourself, but this is something that the government actually does pretty regularly. There was a paper that was published pretty recently about how they found these medications in the backseat of a car from like 1950, and the medicine was super old, but they tested it and it was still within 90% of its potency. So the government has caches of medicines, and they test it every so often after its expiration date to see if it's still valid, and then they keep those caches just in case. But we obviously can't test medications for potency, so we cannot do such a thing. So that is something that is done somewhere else. So I'm going to talk a little bit about concentration, because I feel like people get kind of cross-eyed when we talk about changing this stuff. But I just wanted to show you that it's not anything it's nothing crazy. It's nothing that anyone has to worry about it changing fundamentally what you do. The amount of medication is given an amount of something, whether it's a volume of liquid, whether it's a pill. You could really do anything. In this particular slide, I'm talking about rectangles. It doesn't really matter. It's amount of this inside of that. That's concentration. So as long as the thing is the same, it really functions in the same way. The only thing that changes is the amount that the patient has to have. So what happens is the same, whether it's their allergy is still an allergy. If you change the concentration, the action is still the same. The side effects are still the same. It just depends on how much of it you would give. So if we look at this, this is the black dot medication. The one on the left side is black dot medication, 10 dots in one blue rectangle. That's its concentration. And the one on the right side of the screen is black dot medication. The concentration is 5 dots per rectangle. That's no different than when we talk about a medication, which is dextrose, 25 grams in 50 milliliters, or 25 grams in 250 milliliters. The concentration is the same, but the medicine itself is exactly the same. So the one that has 10 dots in one rectangle is twice as concentrated, and the one that has 5 dots in one rectangle is half as concentrated. So you can use either one. If you only have the left one and the dose is 5 dots, and that's the only concentration you have, you just give them half of a rectangle. If you only have the right one and the dose is 10 dots, you would give the patient 2 rectangles. So you can really do anything in between, over the amount of the concentration or under it, with math. And I know that makes people like really, really upset, and these are simplistic things. But I want you to at least take away from this that you shouldn't be scared if a medicine comes in a way that you're not familiar, because it's still the same medicine and you still know it. You know, like if you take aspirin, for example, that's a pretty common one for everyone, and you're dealing with one pill, right? You don't want to think about it's 81 milligrams in one pill or 325 milligrams in one pill, right? That's why we give 4 81 milligram pills. It's something that we can wrap our heads around, I think, pretty easily that way. So then the other example I have is the lightning bolt medication. And the medication A, or concentration A, is 4 lightning bolts per 2 splashes of the purple liquid. And on the right, it's 4 lightning bolts per 4 splashes of purple liquid. So I realized just now that I have an error on my slide. Anyway, so if I need to give 4 lightning bolts to a patient, if I'm using the one on the left side of the screen, or medication A, I would only need to give 2 splashes of that purple medicine. And if I would use the one on the right side of the screen, which should be called medication B, I would use 4 splashes of purple liquid, because there's less of it in liquid, so it's spread out more. So that's concentration. So it doesn't matter if it's splashes of purple liquid, or milligrams and milliliters, or grams and milliliters, or micrograms and milliliters, or any of the other crazy things that they come up with to call medicine. It's still exactly the same. If the name of the medicine is the same, we can probably figure out a way to use it. So this is my, if you need to visualize, visualize. I feel like when you look at pictures like this, it's pretty easy to see because you can look at how many of them there are and you can figure it out. If you need to draw a picture or write it down, go ahead and do it. Nobody's going to judge you because you can't do math in your head or you can't visualize it without putting it on paper. That's okay. People are different learners, so do what you need to do in order to make sure you have the right medicine for the patient. Okay, so in summary, I want to make sure we have time for questions. Don't let your licensure level make you complacent. Just because you're an MFR or just because you're a basic, you aren't just either of those things. You're still smart people and you still learn things. I would pick a lot of lower level licensures over a brand new paramedic any day because you learn and read things all of the time. And two brains are better than one. I would love to be able to know that anytime I look at my partner, we can have a conversation about stuff like this. Do your research. Don't let anecdotal evidence or hearsay sway your opinions. Anecdotal evidence is sort of like, I had an experience one time and this is what happened. That can transfer to a lot of different places, but just because you had an adverse reaction or your cousin did or your parent did, doesn't make a medication bad. So make sure you do some research about it. Look around and see if it's something that actually is bad before you make that judgment. So there's several different articles linked there. And then if you don't know about something or a medicine or what's going on, ask your partner, ask someone else, ask a patient, even if it's their medicine, research it, Google it, that's totally cool, and practice it. If you aren't good at it, practice it. Obviously don't practice on patients, but you can practice on paper or you can practice on your partners because they're usually pretty willing to work with you on things. So this is my phone number in my office and my email address, and Emma will attest to the fact that I'm pretty good about returning emails and phone calls. But does anyone have any questions? We have 10 minutes, it looks like, for questions. Terry would be so proud of me for getting 50 minutes out of 60. So.
Thank you, Emily.
You're welcome.
I didn't want to cut you off. I just wanted to let everybody know if you have a question or comment at this time, please unmute yourself. I know that last month when I did this, I actually unmuted everybody and we kind of got some background noises. So if anybody has any questions, comments for Emily, you can go ahead and unmute your line or you can use the chat box at this time. Does anybody have any questions? Wow, not one.
I don't know how to feel about that.
Well, and, you know, I'm surprised, you know, originally we actually had quite a few people signed up for this webinar, so I'm not sure if something happened in people's schedules. But if no one has any questions, oh, it looks like you're getting some feedback right now, Emily, in the chat box. It looks like it says that good info was provided, and
Joe asked if mag sulfate is going to be used for asthma. No, I don't think so. Yeah, what I would say is if your medical director wants to do it, then that would be something that could be discussed. The problem with mag sulfate is because of its side effect profile. It's not in there right now. As far as the respiratory stuff that got added, racemic epinephrine is standard. I'm trying to think if there was anything else that got added specifically, but no, not mag sulfate for standard treatment.
Emily and Emma, it's Nancy.
Yeah?
Way up north. We had a tree go over our line, and it was electricity was out. We had fire on the pole and whatever. So I did join you late, but I will go over the PowerPoint tomorrow. And okay?
Thank you,
All
Nancy.
right. Well, thanks.
I see that you joined us late, Nancy, and I did get your email. I hope everything's okay up there.
Well, the power came back on, so I ran over and got the computer going. So I think we're okay.
Okay.
Well, that's definitely a lively way to spend your Wednesday evening.
I guess. A lot of high winds up here, gusts to 45.
Wow.
Yeah, the Sioux said that it had 45 wind gusts.
Oh my goodness. Well,
Yeah.
please.
Yeah, that's windy.
Yeah. So at least it came back on. That's a good part.
Yeah, no kidding. Well, thank you, Nancy. Do you have any questions for Emily for the part that you were here?
No, I'm going to have to look at the beginning. You know, it's what I heard was a little over my head, but I'll work on it.
Okay. Thank you for the feedback.
Thank
Is there anybody else on the line that has any questions or comments?
No, Bob didn't join us for this one.
Okay, thank you.
Thanks.
Any other participants on the line that have any questions? Just a reminder, as I mentioned at the very beginning, I have recorded this webinar and I will post it on the MCRH website under the EMS webinar section. So I will hopefully get that at the end of the week on my website. And then just another reminder, you'll have 2 weeks to fill out the evaluation quiz and attendance sheet, or by November 1st. And so look for cheat sheets then, but if anybody has any questions or comments after this webinar, as Emily mentioned, she did put her information up on the PowerPoint and everybody has my information. And then just to let everybody know, we will have a webinar next month, so please look out for that. Registration has not opened yet for that, so I will be getting that out to everybody in the next couple weeks.
And thank
Emily,
you, Emily.
Yeah, you're welcome. Have a great night, everyone.
Thank you, Emily. You too. I'm glad you're back safe.
Me too.
All right. Well, thank you. Have a great night, everyone.
Good night.
Good night.